Good morning. I'm Dr. Sean Coomer, transplant surgeon and chief medical officer of the Kansas City Division here at the University of Kansas Health System. Welcome to Open Mics. Today we're talking about sepsis, an immune response to infection that can transition to organ failure. Every hour without treatment increases the risk of dying. It's not rare. Each year, nearly 2 million people in the United States develop sepsis. But there are new tools to help diagnose sepsis earlier than ever before. Eric Burke developed sepsis and spent a month in the hospital recovering. He joins us virtually today, along with his wife, Janine. In studio, we're joined by pulmonologist Dr. Chase Hall, Dr. Nima Sarani, an emergency medicine specialist, and Dr. Sam Wyndham with infectious diseases. Thank you all for being here. Yeah. Joining us from Olathe is nurse Ron Chenoweth. He's a senior quality and safety outcome specialist. Thank you all for joining us here this morning. But before we share more of Eric's story, we spoke with pulmonologist and critical care medicine specialist Dr. Steve Simpson on what causes sepsis.
Sepsis is the leading cause of death in American hospitals, and it is the most expensive condition treated in American hospitals. The actual definition that we use is life-threatening organ dysfunction due to a dysregulated host response to infection. You have to be infected to have sepsis. No one knows exactly how to tell when your response is dysregulated right now, but there are people working on this. So with sepsis, there are a number of things that we want to keep regulated, including our immune response, and interestingly enough, our coagulation ability response. In other words, one of the things that gets out of whack, so to speak, with sepsis is our ability to clot our blood and to keep it in regulation. And the coagulation abnormalities lead in blockage of blood vessels that, as I think we all know, every cell in your body needs oxygen if it's going to survive, and when blood vessels get blocked, as in an acute myocardial infarction, you block that important blood vessel here, your heart's going to die, it's going to suffer. In sepsis, you are blocking capillaries, very tiny little blood vessels all over your body, and contributes to the organ dysfunction and death. It was Roger Bone that developed that concept of SIRS. Now, Roger Bone's original criteria said, if you have a documented infection that causes SIRS, yes, you have sepsis. We look at temperature, heart rate, respiratory rate, and white blood cell count. SIRS means either your temperature is too high or too low. Pulse rate is high, meaning more than 100 to 110. And if your white blood cell count is high, meaning more than 12,000. So if you have 2 out of those 4 things, we say that you have SIRS. In 1992, and for the subsequent 25 years, we believed that that was sepsis, and we believed that the organ dysfunction that subsequently develops made it severe sepsis. Now, our definitions have changed. In 2016, a consensus conference again was held. They said SIRS is just a part of infection, and I believe them to be wrong, and I think Roger would have believed them to be wrong, but nevertheless, this is how we have moved. And now the term sepsis, broadly used, means you have an infection that causes life-threatening organ dysfunction.
Joining us, we have Eric and his wife Janine. Eric, thanks for joining us. Many sepsis patients describe symptoms that seem common: fevers, chills, confusion, shortness of breath. What were your first symptoms?
I passed out at work. And from that point on, I don't remember a whole lot for the first couple weeks. Thankfully, I had Janine there to kind of be an advocate for me and kind of walk me through it. But it was probably more of like the worst flu that I've ever had, and just did not feel like myself. No energy, very lethargic, and unable to do much of anything, let alone complete sentences and have thoughts. I mean, it was a real struggle for me for quite some time before I started to feel better.
So, Eric, what point did you realize this was more than just the work flu?
When she told me, I was almost gone, and pretty much it. I mean, it was. I didn't know until I was on the way up that it was as bad as it was. I felt horrible. I'd never felt like that before, but I had no idea. I mean, how close to death I really was.
So you were just toughing it out a little bit. Is that right?
Trying to. I was pretty drugged up and bedridden, and I just had family and friends kind of keeping in touch with me from afar because I was in ICU and ended up with the flu and sepsis and the lung infection. So it was definitely a trifecta of nastiness that I had.
Yeah. So Janine, did you realize the danger of what was taking place?
Not at first. At first, he was admitted technically for pneumonia, and that's what they were so focused on. And I would miss the morning rounds when the doctors would come around because I was home with the kids. So by the time I got there at 7:30 or 8, they were gone. And then the ICU pulmonologist came in and said sepsis, and I said, "Wait, what? I thought this was just pneumonia." And they downplayed that a lot. That didn't seem to be the focus. They wanted to focus on the pneumonia and the infection in the lungs, and they actually let him. He had a lung peel. He was there for 18 days. They sent him home, and his sepsis numbers were still high. So I actually asked for labs the following day because they still weren't down. I said, well, if you're going to send us home, I at least want to get labs the next day. So we did, and 2 days later when those labs came in, his numbers had shot right back up. So that's when we went downtown to the University of Kansas Health System emergency department, and they got us in, and within 48 hours, the sepsis numbers were down. So thank God for that.
Yeah, that's scary. It's sometimes a difficult sleuthing to figure some of these diagnoses out, for sure. Dr. Wyndham, sepsis isn't just an infection, it's immune system failure. We say every hour counts, but how much does time truly matter?
Yeah, it's a good question. I think Dr. Simpson alluded to the fact that sepsis exists on what I would say a spectrum. And so, there's this idea that you could have a pneumonia, you have bacteria in your lung, and your immune system responds to it. Some people are able to get over that hump. They don't proceed to the next step, which we call sepsis. In sepsis, your immune system has become dysregulated, and I kind of think of it almost as like friendly fire. Maybe your kidney takes a hit because your immune system's working overtime, or maybe the bacteria is so aggressive it's causing damage elsewhere. And then there's a group of people who progress to what I consider to be the most severe form, septic shock. And in septic shock, you no longer are able to get blood flow to your organs. Your blood pressure drops, and we have to put you on life support medications to bring that up. Perhaps you have to get intubated so that we breathe for you. So it's important, though, to understand that that sepsis exists on a spectrum. And I think something we've all talked about before is that it's hard to know who's going to move forward on that spectrum and who's not. So a lot of the initial studies, we've been studying this for 20, 30 years now, showed, I think we talked about Kumar. Kumar showed an 8% decrease for every hour in mortality. Those studies have been replicated, and those are really in the septic shock patient group, so the most severely ill. When we move back to the patient groups that are in the sepsis group, which is a much larger group and hard to know who is in that group, we see that mortality may drop by 4 or 5% for every hour that it takes to get antibiotics. And then there is some data that there's a group of septic patients who maybe aren't as sick as we think, and they may not need antibiotics as quickly. And that's why the guidelines, if you trace through the guidelines, they've kind of changed. And now they recommend within 3 hours of somebody with sepsis. And then if you're in septic shock, that bad part, they recommend within an hour.
Mm-hmm.
So.
Yeah, so you said the 8% increase in mortality without antibiotics.
Correct. For every hour that's delayed, there's an 8% increase in the septic shock. Yep,
time is essential. So, and we have Dr. Serrani here, one of our emergency department colleagues. But you're obviously seeing patients before they're in full organ failure. What are the early signs that you're watching for in the ED before the blood pressure crashes?
Yeah, thank you for having me on the show. Yes, I agree with Dr. Wyndham, and usually in these scenarios when a patient presents to the emergency department, our ultimate goal is to catch severe underlying infection before it leads into sepsis and septic shock. So we have to be very keen on some of the subtle findings that can potentially suggest a severe underlying infection. And sepsis is a complex, it's a very almost confusing kind of an illness. You have individuals that come in with chest pain, you do an EKG, and you know that this is a heart attack. With sepsis, it's a lot more complex than that. And we know, based on a lot of studies and also experience, that oftentimes sepsis presents in a very cryptic fashion. We think about infection. Somebody comes in with productive cough and they're running fever. We're like, okay, that's pneumonia. Or somebody comes in with severe sore throat, running fever, it's like it's probably a throat infection. Oftentimes what we see, especially in elderly population and individuals that are immunocompromised, they're coming in with subtle changes. It could be change in mentation, confusion, altered mental status, generalized weakness, fatigue. What Eric mentioned, he was probably having some generalized weakness and fatigue, and then ultimately it led to systemic failure. Likely he was hypotensive, and that's why he passed out. But we have to be very keen at identifying underlying infection just based on very subtle findings. So we have clinical scenarios that's helpful, patient's history, and then physical exam, obviously very important. Do a head-to-toe exam. Note if they have any accessory things such as Foley catheter or devices that can potentially get infected. But additionally, we rely on vital signs like Dr. Simpson mentioned as far as the SIRS criteria, elevated heart rate from their baseline. Also, we have some lab work that's helpful to us as well.
Yeah. So you probably see a ton of folks with pneumonias, flus, UTIs that never will get to sepsis, but it's picking out the ones and identifying the subtle hints that might head them in that direction. So sepsis is one of the most common pathways to acute respiratory failure. Rapid, shallow breathing is often the first sign. This is happening before any lung damage is visible. So, Dr. Hall, what are some of the early indicators that the lungs and brain are already being affected at the microvascular level?
Yeah, I think it's important to realize that these effects are happening before we see the signs and symptoms of them. In the hospital, that's usually when I see a septic patient, someone with sepsis, is after they've already been admitted to the hospital, come through the ED. They may have a slight increase in their oxygen requirements that's slowly creeping up over time. Maybe not even notice it. They may not even complain of shortness of breath. That can be one of the early signs. As mentioned, kind of shallow breaths, more rapid breathing may take place, and that's a sign that the lungs are being involved. As far as mental status, actually the family members are often the first to notice this. They know their loved ones best. They notice that they're a little confused, saying things that don't quite make sense, some fluctuating mentation, and those are signs of brain dysfunction.
So we're gonna put you to the test here. So we have some scans of Eric's lungs. Can you walk us what we're seeing here?
Sure, yeah. So let me see if I can see it from here.
That one.
So if you look at the CT scan, I'll kind of just walk it through like I walk my patients through. On the left side of the screen is actually the right lung. On the left side of the screen, on the left side of the screen is the right lung. On the right side of the screen is the left lung. And we're kind of at the somewhere near the middle on that left image. On the right image, we're a little bit lower down in the heart, and we're starting to see towards the left lower lung. There's some consolidation there to be consistent with the pneumonia.
Yeah. And when you say consolidation, that means that it's sort of collapsed. It's got a lot of mucus maybe and fluids.
I should walk you through it a little bit more. So the lung on CT scan is normally black because air shows up black on a CT scan. Anytime there's something in the lung, it usually shows up as shades of gray or white, basically. So the more consolidated it is, the more white it is. There's other things you may hear like ground glass, which is where you still see some haziness to it, but you can see the underlying structures. When there's consolidation, you can no longer identify the underlying lung structure.
So Eric had a chest tube placed to help drain lung fluid. Can you explain why that was necessary?
Yeah, so the fluid in the space between the lung and the chest wall, if that gets infected or inflamed, it can cause damage to the lining, thickening of it. Your lung can stay trapped up like that if you don't treat it. Also in the setting of sepsis and septic shock, if that fluid is infected, we want to get rid of that infection. So there's one thing giving antibiotics to treat the pneumonia, But the antibiotics don't work very well in that space without draining that fluid, so it's necessary that we drain it.
Right, it's hard to get. Antibiotics need blood flow to get the infection on. If there's an infection that's kind of doesn't have blood flow to it.
So obviously, one is the treatment of the infection, and two is to prevent structural damage to that space long term.
Okay. So I'll open this up to anyone. If doctors are missing this diagnosis in emergency departments, how can patients advocate for themselves? Does everyone need to be asking questions about sepsis?
Yeah, I think something that struck me about what Dr. Hall said, especially about confusion. When we see a patient, when you're seeing a patient for the first time in the ED, it's not quite clear what their baseline is. What's really helpful is family members telling us, hey, this is different from baseline. This isn't just grandpa who's usually a little confused. Grandpa's usually doing his taxes still. It's helpful to understand that. And I think that's a really easy way to advocate for your loved ones, is to say, this is different. Here's how the baseline was, and here's where things are now.
Yeah, I think that's a really good point. So Dr. Anand Kumar at the University of Manitoba in Winnipeg did a study of patients in the ICU, and I think we mentioned this earlier, Dr. Wyndham, and learned that your risk of dying goes up 8% per hour before you get antibiotics. So before him, we thought the mortality rate of sepsis was 60 to 80%, and now we know better. We know if we give antibiotics within the first hour, the mortality rate drops to 15%, and that gives us more hope. This, including Dr. Simpson, and here's what Dr. Simpson had to say about the early intervention.
We actually do have tools that are pretty effective, but they're effective the earlier you use them in the course of this illness. So we have spent a lot of time here at KU trying to make sure that our folks understand when to suspect sepsis and to recognize it when they see it, so that we can treat rapidly and aggressively and keep it from becoming more life-threatening in its organ dysfunction or becoming septic shock. So we know that sepsis is time-sensitive. The treatment and the recovery are time-sensitive, and so we work hard on trying to make sure that people get their treatment rapidly and aggressively.
Dr. Simpson mentioned tools to recognize sepsis. In January of last year, the FDA approved blood tests to detect sepsis earlier by identifying biomarkers linked to immune dysregulation. We know this improved traditional methods, which were slower to diagnose. This helps identify bacterial versus viral infections. Dr. Hall, how do these improve detection compared to traditional cultures?
Well, I think the important thing to realize is that when we draw a blood culture, we're not going to have a result for 24 to 72 hours. So there's a delay there. Really, that's for future us to know how to manage the infection better once the results come back. So some of these tests can help us identify this immune dysregulation that we mentioned sooner, so that we can be more aggressive up front with our treatment and trying to prevent moving on to septic shock and other conditions.
Yeah. I mean, I think that's important you brought up the cultures, right? You're treating empirically, meaning you're giving broad spectrum antibiotics or whatever else you add to those adjuncts until you know what specific bugs, you can narrow it down and actually go right after that. So, so let's go to Olathe and bring Ron Chenoweth into this conversation. Good to see you, Ron. Ron, from a nursing perspective, what are the earliest red flags of sepsis, and that can be easy to miss, and why is that the first window so critical before it progresses to septic shock?
Well, I think it's been said earlier that you have to watch the patient closely, and the family members are that front line, but nurses are the second line. They would be able to watch and see mental status changes, changes in the work of breathing, as well as vital signs. And an important thing to do would be to actually maybe get a set of vital signs if you are starting to notice those changes, because not all units are doing them hourly, and they get a little spread out. So we would want to maybe capture one, look at them, and see if they're trending in the wrong direction.
So Ron, your team is also using AI, or artificial intelligence, to help identify sepsis earlier. How does that technology work alongside clinical judgment, and how is it changing the speed of diagnosis and treatment?
Well, we're currently working on a new model. We've had the version 1 for a number of years here at the University of Kansas Health System, but we're now working on version 2 and looking at another option as well. We hope that when that triggers, we're actually going to be 4 to 6, maybe even 8 hours ahead of what we would consider a true sepsis patient. It would give us that opportunity to assess and then order the right treatments, whether that's just a lactate or cultures or antibiotics, but we could maybe phase it in and set some sort of standard of care so that we know that we're capturing it correctly.
Right. Dr. Serrani, how are you using AI in the emergency department?
Like Ron mentioned, we are currently don't have an AI platform in the emergency department. We got to understand that we're still at the early phases of AI in the hospitals, including emergency department. One thing to keep in mind is, ultimately we want to make sure that we are providing a 24/7 monitoring to our patients, and the gold standard at this point is when the physician and nursing staff is at the bedside with the patient evaluating them. But unfortunately, in reality, that's not the case. And so we have to rely on some additional intelligence, such as artificial intelligence, to key in on certain changes, certain laboratory values that come in, certain vital sign trends that are changing, to then notify us that there might be something going on. There might be an underlying infection going on. Given the fact that we're in early phases and most of these platforms are validated externally, one of the main things that any health system has to do, which is what we're doing, is do our due diligence. Before adopting the platform, making sure that they're internally validated, they are tinkered and tailored to our patient population. As we know, disease prevalence differs based on community, and that's what we're in the process of doing, and I'm hoping that in the next few months or so we can go live with one of these models.
Dr. Wyndham, could these tools move sepsis diagnosis upstream, meaning earlier, diagnosing patients before they reach organ failure?
Yeah, I think that's the ultimate hope of all of these tools that we are coming up with, whether it's a test on the blood, whether it's AI modeling. The hope is that we can catch people in that early period that I kind of talked about, that severity spectrum. Because we think that if you're able to stop someone from progressing to sepsis, you're going to stop them from progressing to septic shock. And maybe if you catch them early in their sepsis phase, they won't progress to septic shock. That's kind of, I think, the holy grail, I'd say, of all of these tests.
Dr. Hall, for patients who survive this severe sepsis, especially those who require ventilators, what kind of long-term pulmonary complications do you see, and how common is lasting lung damage or reduced function?
That's a great question, and it largely depends on where the infection was and how sick their respiratory status got. In Eric's case, with his lung being involved, there's risk of structural damage from the pneumonia itself, especially if he did have an infected pleural space. That certainly could lead to some long-term damage. On the ventilator, we try to protect the lungs as much as possible. We don't want to push the air in too hard with the ventilator that causes more damage. So long-term, most of the time patients will not have long-term lung structural damage from the ventilator or from sepsis itself. However, if they develop ARDS, there may be a risk of fibrosis that persists. Out to a year, most people's lung function will be largely normal, although they may have some impairment in gas transfer. I think importantly is the actual effect on the body from weakness. Being in the hospital, laying on a bed, having machines do the breathing for you, tremendous amount of weakness and long-term recovery from that standpoint.
Mm-hmm. Yeah, I think one of the adages everybody says, you spend one day in that situation in the ICU, that's a week of rehab.
Yeah,
to get back
exactly.
to a
Absolutely.
baseline. So, Eric, how's your lung function doing today, and what are the biggest side effects for you as a patient?
2 years out from it, so it was almost 2.5 years. It's great. I mean, I don't feel any ill effects from it. For that first, I was probably 3, 4, 5, maybe even 6 months. It was definitely a struggle to build up my energy again, to get that full lung function, to just kind of start to feel normal again. They told me a year and a half, I would still feel some of the after effects of the surgery, of having everything cut open, and I still to this day on my left side, it almost feels like it's still kind of numb. But I haven't had any ill effects of breathing. I mean, I can run with the kids or run from her or run with the dogs, do whatever I need to do. Now everything's good.
Well, we're glad you're fully recovered to escape, it sounds like.
Yeah, I've got my mind back too. Everything's good. Everything's good.
Yeah, you're going to be in trouble after this show.
Yeah.
We're here to answer your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hawk. Doc Hawk, the weather's very nice now, and people are getting outdoors more. And besides wearing sunscreen to protect from UV rays, what is another important thing for people to do?
Yeah, you know, again, I think if we can get through these bad storms and keep everybody safe, that's a good thing. We talked a couple weeks ago that we are leaving respiratory viral season and entering into vector-borne disease season. So these are diseases that are transmitted by insects mostly, especially mosquitoes and ticks. And while the main mosquito disease around here is West Nile virus, we do have several different ticks in our area, and these can spread diseases. So this includes the deer tick, which can transmit Lyme disease, anaplasmosis, babesiosis, ehrlichiosis. There's also the American dog tick, which can carry diseases like Rocky Mountain spotted fever, tularemia, and all the other diseases that I just talked about are generally bacterial diseases. Now, there is also another tick that is around our area called the Lone Star tick, and it's important because it can carry bacterial and viral diseases like ehrlichiosis and tularemia, as I mentioned, but also Heartland virus and Bourbon virus. And you can see on this graphic the range of that tick. That is what that is. That graphic is showing. So I think that is important to understand. We have all of these ticks in our area. Now, I would also like to say that we have very little to rare Lyme disease in this area. Those other diseases are much more prevalent.
Yeah. You know, there's another reason you showed on that map. I mean, a lot of eastern Kansas and Missouri has a lot of this, but there's another reason why it's important, because also transmitted could be the alpha-gal syndrome. Alpha-gal syndrome is important in becoming more prevalent. So it turns out it's an immune reaction to a carbohydrate sugar molecule found in our bodies. It affects people when they eat beef or pork or lamb and venison. And in 2 to 6 hours, people become very ill. They can break out in hives and have gastrointestinal issues. It is not triggered by other meals, other meats such as chicken, turkey, fish, and other seafood. Is there a test for alpha-gal syndrome, Doc Hawk?
Yeah, you know, again, you know, all of those things you said are very important to understand, and it is growing in prevalence, unfortunately. So is there a test? Yes, there is a blood test that actually looks for an immune globulin, or IgE. This is a specific type of immune globulin that our body makes, and it is reactive to alpha-gal. If there are these antibodies in your body which we can detect, you may have the alpha-gal allergy. And the allergy and abdominal or stomach symptoms can be caused by that allergy. And just as you said, when eating mammalian meat rather than things like fish. So it is important to understand that.
And what if someone does get this allergy? What's the treatment for it?
Yeah, unfortunately, the main treatment for alpha-gal allergy is really to abstain from those foods that can cause those symptoms. So just as you talked about the meat, the beef, pork, etc., and any products made from them. In fact, some patients may also have allergy symptoms from eating or consuming dairy products, things like cheese, butter, cream, and milk as well. Other times people have problems eating gelatin, which can be made from the bones of cows and pigs as well. So it can span different foods or food groups as well. And I would say that the most important thing, as we have talked about before, is prevention, whether that's vaccines or whether that is sunscreen now, like you said, when the weather is turning nice and people are out. For ticks and mosquitoes, it is going to be that prevention. It is understanding where you're going, what time of the day you're going out, the environment that you're going to be in, using a insect repellent, especially with DEET in it, to help protect from getting those tick and mosquito bites, wearing long clothes, and of course, when you come in from walks or being out in nature, doing those tick checks on your body to look for those little bugs.
All right, thank you, Doc Hawk. Appreciate it. We know many of you have questions. Let's head to Studio B with Alexis.
Well, Nate, one of our viewers, wants to share a really alarming story. Nate shares, my husband survived sepsis in the ICU in a different Kansas hospital in 2007. And for 2 weeks, he was lying in the balance, misdiagnosed when he got strep throat. By the time they admitted him, he was bottoming out. We are so lucky he's healthy, that he's not lost limb and organ function. I want to encourage family members to be advocates for your loved ones. Stay aware and stay informed. Boy, that sounds scary. And then our viewer Jeremy writes, he has a question about the video that aired at the beginning of this program. He wants to know, it said sepsis is one of the most expensive things treated at hospitals. Why is that?
You want to take that?
Yeah, it's a good question. I think probably one of the biggest reasons it's so expensive is because we don't have the tools to catch it when we should be able to catch it. You know, if you catch say an early heart attack, we're able to intervene and make sure that the muscle gets blood flow again. What we've been saying all morning is that it's hard to catch sepsis before it turns into worsening organ damage. And so in my mind, because we don't have these tests, because we can't tell who's going to get sick and who's not, that's really why it costs so much money. We just are working on the back end of things.
Yeah, I mean, in general, the longer you spend in the hospital, the more it costs, right?
Right.
More resources and things like that, and that costs money. So this has been a great discussion. I'm extremely grateful to our guests for being here. And I want to get some final thoughts before we go. Eric, what do you want families watching to hear?
Listen to let your family be your advocate. Everybody asked me, how was it? I don't remember 95% of my time in the hospital. I was just that out of it. But if it weren't for Janine being my advocate and getting me out of one situation and down to the University of Kansas Hospital, then she'd be sitting here alone and we'd be having a much different conversation.
Oh, God.
You know, with 2 young kids, you know, I just can't stress enough. If you have a concern, make sure you voice that concern for your loved one. That way they can be the advocate for you.
Janine, what's your takeaway from all of this?
Well, again, I just speak up. Don't be afraid to ask questions and speak up. And if something doesn't feel right, or if you have more questions, then get a second opinion or go somewhere else until you feel comfortable that what's happening with your loved one or with yourself is being handled to your liking, until you know your body's best and you know your loved one's best and how they should be acting. And if it's still not right, then find a doctor that will help you and keep looking until you do.
Yeah, well, thank you both for being here and sharing your story. We really appreciate it. It means a lot. We also asked Dr. Simpson what he wants viewers to know.
My final thought is that you will see and hear that Sepsis Alliance is going to launch a campaign that we call TPR. We like that moniker because everyone's heard of CPR. What we want to do is save lives of people with sepsis. And you will see that we will be teaching the general public about monitoring their own temperature, monitoring their respiratory rate, monitoring their heart rate, and then you can even add some things on. Some people have pulse oximeters at home, so we will teach them how to be concerned if their blood oxygen levels have dropped. And some people have blood pressure monitors at home, so we will be teaching them also. You know, if TPR is out of whack, check your blood pressure if you have the monitor at home. If your blood pressure is low, get attention immediately. That sort of thing. For the last 15 years, we've been doing surveys of the general public, and we went from, in 2010, only 19% of the general populace had ever even heard the word sepsis. We're up to now 75% have heard the word sepsis, but our level, when we delve into it deeply, of how would you know if you had sepsis, is still lacking. So that's why we're going to work on this TPR campaign.
Ron, any final thoughts?
Yes, some of the work that we're doing with quality and safety and some various stakeholders in the organization is we're working on some back to basics sepsis education for all of our staff. In addition, we're trying to smooth out sort of the confusion between Sepsis 2 and the Sepsis 3 definitions in documentation and capture, just to improve that overall understanding and how payers and CMS align with what we're doing for the treatment of our patients.
Thanks, Ron. Dr. Srani?
Yeah, thank you again for having us on the show. This is an incredibly important topic, and it definitely requires a lot of attention. I'd like to just resonate what Eric mentioned. You know, with sepsis, like we discussed multiple times here, it's a very complex, it's a treacherous, cryptic kind of an illness. So it's very important to hone in on subtle changes, especially within families that you know what the baseline of your loved ones is. If there's change in mentation, confusion, generalized weakness, fatigue, lightheadedness, dizziness, multiple falls, to key in to think about there might be a potential underlying severe illness going on that's resulting in this, to seek help as quickly as possible. If concerned, to come to the emergency department and get a comprehensive evaluation. And on the other side of the token, it goes to the providers as well. Because of the fact this is such a cryptic illness, it's incredibly important for us as providers and staff, nursing staff, physicians, to always have sepsis, to always have severe underlying infection in the back of our mind in our differential diagnosis, even though when the presenting symptoms are not pointing towards an infection. As long as we have it in the background in our differential diagnosis, it makes sure that we don't miss it. Oftentimes, unfortunately, it doesn't exist because of all these other more loud types of illnesses, such as heart attack or patient that comes in with multi-system trauma. And oftentimes, we miss it because it doesn't exist in our differential diagnosis. So we all have to kind of think about it, always have it present in the back of our mind. Otherwise, it leads into poor outcomes because of delayed care and delayed management.
Thanks. Dr. Wyndham?
Yeah, I think, again, echoing what Dr. Srani just said, sepsis care is really a team sport, I would say, and that team includes the patient and their family. We really rely on patients and families to help us understand what's changed in a patient, and I think that's an important thing for every patient and their loved ones to hear.
Dr. Hall?
Yeah, I would echo what everyone else has said, really. I think importantly for sepsis, we want to be very sensitive, not necessarily as specific. We want to catch cases early and treat it. If you're a patient at home, listen to your body. If things aren't right, doesn't hurt to get checked out and make sure, because once it progresses, it's very hard to treat and it can lead to prolonged hospitalization and complications.
Okay. Let's get back to Alexis to hear what she's working on for tomorrow's show.
We have a great show coming up, Dr. Coomer. Millions of women are living with undiagnosed pelvic and leg pain discomfort. They're struggling, but they're left without answers. You're going to meet an RN, Heather Figury, who finally got diagnosed and relief here at the health system. You're going to learn about the condition that impacts millions of women and the procedure that finally can fix it. That's tomorrow at 8 a.m.
Well, thanks again to all of our guests and to our audience. Remember, faith, hope, and science.
Subscribe to our morning medical update and open mics with Dr. Stein's podcasts. Now, everywhere podcasts are available.